This is the patient who presented with pelvic pain.
Are we supposed to focus on the adnexa? I saw like 2 cystic things in the adnexa.
You can focus on whatever you want. But yes, it's in the pelvis.
Okay. I'm not sure they're adnexa. They look kind of posterior.
Would you dictate in your report? Can I just start from the front and then go to posteriorly?
One of them looks almost like a dilated tube to me.
It's the final diagnosis is not adnexal related.
Yeah.
There's
They're almost like cystic things coming off the back of the uterus.
The back of the uterus. Oh, those are the adnexal things. Yeah.
You're saying don't even just ignore those?
Yes.
Okay.
Is that part of bowel, or is that soft tissue just in front of that cystic lesion with some speck of calcification?
Oh, it's I think probably part of the adnexa, but not the primary finding.
Looks like there's like fullness in the perineum. Or wait, can you go through the axial again?
Yes.
Oh, rectal mass?
Good. Yes. So let me see if I can. And here's the MRI. So a patient got a colonoscopy and there was positive findings. And then the patient underwent an MRI. And this is what it looks like here. So there's it's a rectal cancer. This was a staging MR. Here it is. And the thing that T2 shows the size of the lesion a little bit better here. There's a flat part of it and there's more of like a rounded part of it. So the adnexal thing, those were simple cyst on MR. So and I can show you the T2 here. So just cyst. They didn't have any T1 hyperintensity, so they weren't endometriomas. And the rectal finding was what was subsequently worked up and managed. So, but yeah, pelvic pain, it's easy to kind of focus in on the GYN structures and rectal. It's it's a hard call, but I think sometimes you can maybe, I don't know, they're just hard in general. So and can be very easily overlooked, especially when the bowels collapse like this. So
nice call.
Can I go next? Because I might have to disappear in between.
Yep.
So this is a young guy with psoriasis. He is started on a new treatment and a couple of weeks later presents with features of colitis. CT is done, and what do we see?
It's like near pancolitis.
So
with lots of lymph nodes.
the patient is put on this newer drug called ixekizumab.
Hopefully they have a nickname for that.
Taltz, Taltz.
Okay.
So this is IL-17 inhibitor, and this is known to cause IBD-like symptoms or like IBD-like features, both Crohn's and ulcerative colitis.
Wow. So it's
Wow.
basically mimicking an immune, like an autoimmune disease kind of thing, because it's working on the immune system.
Yes.
Wow. Thank you.
And that's how his psoriasis looked like after drug.
Yikes.
Like it improved.
Mm. Okay.
Case here, can you see it? This is a young man in his 30s. He comes in with, it's a evening right before major holiday, as in like 4 p.m. right before major holiday. Patient comes in into ED, and the story is abdominal pain. They think he's an academic, I'm sorry, he's in diabetic ketoacidosis, but he's in a lot of pain, so they decide to do his scan.
Bowel looks
bowel is-
ischemic.
Yeah, it's not enhancing.
Right. So let me do the corona.
And there's hypertrophy of left ventricle.
Yeah, I'm not going to dispute the ventricle because I can't talk about it. But
Is something happened,
You
like
can-
some kind of swirling or
Like a
movement?
hernia. There's an internal
Yeah.
hernia.
right. So you can see that, right. So you can see that the proximal small bowel loops are collapsed. He's not vomiting, it's just abdominal pain. Then you can see that there are a bunch of bowel loops which have like a C shape. And then there's you can see like there's one
Yep, there. Yep, right there.
transition point here and there.
Yeah.
So I was going to say, okay, maybe there's what do you call it? There's a closed loop small bowel obstruction, but then as I was scrolling through, there's additional two, what do you call them? Like obstruction points, right? They're all here.
So is
You
it
can
like
see
an
there's additional-
adhesion that is causing multiple bowel loops to be obstructed at that spot?
So then as you move the SMA and SME, you can see that whatever the process is here, it also affects like SMA
Like
and
shutting off the
go right
vessels.
into it.
Yeah, look at that. Look at downstream.
And
There's
it's-
no flow.
Right. So SMB is completely obstructed. SMA, narrowed, probably some flow. Just anyway, so I called them. I said, there's clearly closed loop small bowel obstruction. I have very high suspicion that there's internal hernia and very high suspicion that there's ischemic bowel. So they took the patient to the OR, and the patient pretty much had he had internal hernia. I have to look up which type, like he definitely had internal hernia, just forget which type. I think, or not paradodenal. I'll look it up in a second. But anyway, so he had hernia. Most of his small bowel was going through the hernia, into the hernia. And he actually ended up losing most of his small bowel, with the exception like the first 20 centimeters of small bowel. Everything else was necrotic. So yeah, they were absolutely not prepared for this. They thought that they did have labs that his lactic acid was high, but his sugar was really high. So they kept thinking that he's just going into DKA and not thinking about, like any kind of bowel ischemia. But this is probably the most extensive internal hernia I've ever seen, and it was just tremendous ischemia of bowel.
Yeah, that's scary.
This is a case similar to what Dr. Tan showed last week. So this is upright view. And this is left lateral decubitus.
Oh, wow.
Wait a second.
Wait,
Okay,
is
I'll
it
go
like
again. I'll go
ectopic?
again.
Is
Sorry,
it a
sorry.
wandering kidney or is it
Is it
like a
wandering to
renal?
the other side?
Yeah,
Yes.
exactly. Like, oh,
Okay, I'll go again. I'll go again. Sorry. So this is the regular supine view. And then in the upright position, both the kidneys descend. The right kidney descends 10 centimeter, the left kidney descends almost 7 centimeter down. And then in the left lateral decube, the right kidney goes over the other side.
oh,
That's
it's like
crazy.
floating.
And we have ultrasound also of this. So that's the
Oh,
midline.
wow.
What?
And this is
Sliding
the
across the
vertebral line.
midline, yeah.
And if you see this impression, so this is the patient's hand which is pushing the kidney on the other side.
Like, okay, you belong on the other side now.
Ah,
And
wow.
after PEC, there is some improvement. So this is supine again. Supine. Right lateral decube. Left lateral decube. So at least the contralateral thing is gone down. But the right kidney still descends down. So right is still totic, left is not totic, and right does not go on the left side.
Very cool. And when you say pexy, like, do they just like sew the kidney to like the psoas or something?
That's a good question. I didn't see
I've just
that.
never seen a pexy, I guess. Okay, I'll let you look
Um,
that up. Okay, so this person, obviously something is up with their kidney. It's got this very heterogeneous enhancement, almost like a striated nephrogram. There's also some mild hydro. Follow the ureter down. And there's like a little bit of fluid here. They recently had a hysterectomy. So we thought, this is the vaginal cuff, like this amount of fluid is not that unusual for recent hysterectomy, but why is there hydro? And it kind of terminates in that area there. Any thoughts?
Ureteral laceration.
Yeah, but like, so if you think if there's a ureteral laceration, why is there not more fluid down here?
When was the hysterectomy?
A few days ago.
Why was the hysterectomy done?
Just for fibroids.
So did
There's
they
lots of
ligate ureter by
Yeah,
mistake?
so it could be ligated. Exactly. But why isn't there more hydro? We just didn't understand, like putting all the pieces together.
and patient doesn't have pylo.
I'll just show you what's going on. So this is the now excretory phase. Luckily we had this. And you can see that there's just extrav. So
Oh.
Kelly, you were correct that it was lacerated. So we still
Should
did
you get the sagittal? Is it extraved into what? Into the
exactly. I'll show you. Hold on. You'll see. It's actually extravasating
fistula.
vagina. Yeah. So this is why there wasn't a lot of fluid accumulating, because not only was it lacerated, but there was actually a vaginal dehiscence. So the symptom, I kind of withheld some history, but the symptom was that she had urine coming out of her vagina.
Mm.
So yeah, you can see the contrast going all the way out the vagina. So it was a complicated hysterectomy. So, but then anyway, they ended up putting in a nephrostomy tube, and then they did a ureteral implantation and doing fine now. So.
This is it's a patient with liver lesions, and we have hepatobiliary phase imaging. So I have multiple, like over time. So there are multiple lesions that look like this. So that's there. And here's the hepatobiliary phase. So there's hepatobiliary phase hyperintensity. There's one there. There's another one.
Centralish scar, right?
Is there a centralish scar? I don't know. I didn't appreciate it.
Feels like a branching scar. Like there's a scar, but it also has branches to it.
So there's multiple let's see if I can. Let me bring up the arterial phase. So some of the lesions are stable, but the larger one is increasing / new. So there's a lesion here, like, and where is it? Here. This is the big one. And then this was like 4 or 5 years prior. So the larger one wasn't really there before. This one.
Wait, but can we see the arterial phase before? Because what you showed was for the lymph
Yes.
phase.
Oh, yes, yes. So the arterial phase is here. There it is.
So it was there.
This is
Right.
4 years later. Before, this was 4 years prior. That's the arterial phase.
So it was there, but smaller.
Yes, much bigger now. I mean, not like 4 years later. This is not a current study, but yeah.
And how old is this person?
Person is youngish.
I still
Um,
think it's an FNH.
And it
Me
some of the
too.
lesions restrict a lot. So like this one laterally, that one restricted quite a bit. So I was looking online and I found out that like 20 to 30, there's a meta-analysis in AGR looking at hepatobiliary phase hyperintensity for inflammatory adenomas, actually adenomas in general. And it was written, actually, it was Richard Doe,
Right.
you know, MSK.
So
Go ahead.
yeah. No,
And
just finish your statement.
the paper said 30% of inflammatory adenomas retained hepatobiliary phase hyperintensity. Like it took a Eovist. And I was surprised by that number because, typically we think of FNH if it has, if it retains Eovist. And this one retained Eovist, but it was much bigger and it was restricting. So then I guess it made me more confused than clear, right? So the classic teaching has been if it retains Eovist, then it's FNH. But if a third of inflammatory adenomas don't, then I mean they also retain Eovist, then like how do we distinguish those two? This one also had like a
So,
pretty rapid growth, and it had like the T2 signals intermediate. I want it to be more kind of that stealth lesion, like more a little bit more closer to the liver signal, but it was more hyper and then had some restriction. I don't know. What are your thoughts about it? And I'll tell you what the path showed after.
so I think one thing that the literature doesn't take into account is that they don't take into account the pattern of Eovist retention.
Yeah.
So, and I think there was a follow-up study that kind of sort of tried to do that, where they looked at not only just yes and no binary, like where it retains Eovist, but like if it's homogeneous, if it's heterogeneous. And so if you take into account heterogeneity and like pattern of retention, then you go back to, to what do you call it? To what we know. There's a different meta-analysis that looked at having, I think it's a little earlier than the one that you're referring to, that looked at FNH versus adenoma. And they looked specifically at having areas of hepatobiliary phase hyperintensity, and they showed it's 95% like specific for separating the two. The truth is probably somewhere in between. But I think that, like, if you take into account the pattern of retention, it's not 30%. It's going to be somewhere between 5 and 10% of adenomas that will completely mimic. And I think in this case, if it's growing it too much, and if there are features that make you concerned, then I think whenever there's something that doesn't fit your comfort level of saying this is like typical behavior for benign lesion that we don't need to do anything, then I think it's a good idea to either follow it or biopsy, depending on the level of suspicion. But I would take that meta-analysis with a grain, not with a grain, but like put into context. It's not, they didn't take into account the pattern of retention of Eovist, just yes, no.
So what is the pattern of enhancement for adenomas or hepatobiliary uptake that's different from FNH?
Very few of them are going to have like uniform uptake the way that FNH has, and they won't have that. You know how FNHs have either a donut appearance where the central scar is hypo, and then you have periphery that's either iso or hyper. Sometimes you see almost like a colloquial pattern where like it's relatively uniform iso hyper, but then if you pay attention, you see like very thin hypointense septi, like radiating from the center, right?
Mhm.
So, yeah, I think that's the paper that I was talking
So
about.
I'm just gonna show. So this is the paper that I just Googled. Hepatobiliary phase pattern of hyperintensity adenomas versus FNH. And I'm looking at the figures. So I just there's figure 1, figure 2. This is this is what I think inflammatory adenomas here. So figure A shows a homogeneously strong FNH in the left lobe of the liver. So this is figure A. Can you guys see? Let me see if I can make this a bit bigger. So you're saying that FNH have more homogeneous and kind of robust uptake all throughout the mass.
Yes.
In contrast,
and they may have, right?
Go ahead. Yeah.
Yeah, no, go ahead.
Oh, and then the atoll sign. So there's an atoll sign that so homogeneous versus heterogeneous patchy enhancement. So the inflammatory adenomas have more of like a patchy, like kind of a pseudocapsule-ish atoll appearance.
Right. So there's an old study of an AJR from like 20, I want to say 12, 13, but somewhere around that time. And they looked at a bunch of lesions with hepatobiliary phase hyper enhancement. And they showed that the hypo-enhancing rim was very suggestive of malignancy or like non-FNH, non-benign thing. So that's kind of a should ring a bell that this is something not an FNH. And then heterogeneity, like these patchy areas of decreased hepatobiliary. So what was the path?
FNH.
Right.
Yay.
And FNHs can grow. And for reasons that I have no explanation for, but the FNHs that we had when I was at MSK, almost all of them had diffusion restriction. I don't know if it's like they were selected, like it was like a selected subpopulation of more typical ones. But yeah, it was interesting.
Nelly, did they resect it or biopsy it? Just curious.
Biopsy.
Yeah. That makes sense. I agree with everything that you guys have been saying. Like the more the adenomas that are retaining are going to be the more heterogeneous or patchy ones. But, if it has atypical features, there's no major harm in biopsying it. But this one, that I do feel like the Eovist retention still had even though it had branching areas that weren't retaining, it was overall very homogeneous. That was more suggestive of
I agree.
And they restrict. That's the other thing. So FNH, they do restrict pretty.
They can do several things. They can restrict, like yours. They can be they can be T1, T2 bright. They can have fat in them, just like the adjacent liver has fat. So I think there are some atypical features of FNHs, but like that shouldn't make us be like, oh, that's not an FNH. They're just a little atypical. So
Yes.
Okay. This is an interesting case. It was a man. It's not an eye test, but
like a T2
he
bright.
had
Pancreatic
several findings, right?
mass.
So he had
Subcapsular.
this mass,
Subcapsular
right,
retraction.
in the liver, right? I just want to get the arterial phase there. You can see this lesion, right? You know, kind of targetoid appearance on T2. There's a retraction from the
Sclerosing
capsule. There's
hemangioma.
target.
Do we have old
They had,
studies?
they had a huge pancreatic mass too.
Wait, this is not a straightforward case, but with this appearance, you don't want to say immediately. This is intrahepatic cholangio.
Yeah, I was gonna say.
But yeah, whenever you see this, like target to T2, target those are really very, very scary things to have. I'm just going to make it okay. So anyway, so we had this with a little satellite nodule. Then there was a segment 8 lesion somewhere that was questioned. Maybe we didn't even see it. No, that one. Barely could see it. And then, of course, there was this humongous mass in the pancreas. Right there, right? It's mostly T2 hyperintense. Has a lot of internal structure. It looks like it's communicating with the tail. Looks like it's going into pancreatic, into gastric wall.
That the communication with the tail, to me, that makes it look like this huge IPMN with probably like malignant degeneration, and then fistulizing with the stomach.
Right. So this is for CT from 5 months ago. You can see kind of the mass is less than 5 months, maybe like 3 months ago. I don't want to unblind take out the anonymization. But this mass was really unchanged from like about 5-6 months ago. Maybe the extension into gastric wall was worse. Anyway, so this was called an indeterminate. You can see all of this is enhancing components. This was questioned to be cholangio with like little satellite lesions. The patient actually had it for resection and had resection of segment 4 for this lesion, resection of the pancreatic mass, and actually had a resection of segment 8, so somewhere here. So the path came back as intrahepatic cholangio with adjacent satellite lesion. This came back as mucinous adenocarcinoma. And this came back as mucinous adenocarcinoma metastasis. So this little thing is a met of pancreatic cancer, whatever this, adenocarcinoma, mucinous adenocarcinoma. And then this cholangio just kind of has this little adjacent thing, but didn't metastasize anymore. So he had a double whammy.
Did they have a genetic testing?
Not to my knowledge.
It does look like he has background liver disease, so that kind of could explain the cholangio.
I think he has. Just stop recording for a second.
Okay.
But actually, no. So the MR I showed you is from December, and this is from May. This is studied from May. So you can see that this mass is there. I think that at this point they may have thought it was a pseudocyst of some sort. And then there was a mass here. We don't have anything preceding this time.
I still think this pancreatic thing, first of all, that does not look like a pseudocyst. And
I agree.
It still looks like it's probably like from an IPMN. So, and one of the subtypes of IPMN can be like the colloid mucinous subtype. So to me, also like, yeah, the communication with the duct to me, and just like even and I've had several IPMNs that actually have fistulized into the stomach and into the duodenum. So like, that's also another thing they can do when they get big enough.
So about a month after regional CT, they did EOS, and it came back scant cellular material, Bethesda 4B.
What's that?
that's the EOS from this FNA of this cystic thing about a month after this. They said scan cellular material, pancreas, blah, 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 blah. Neoplastic, other Bethesda, category 4B. So this is mucinous, pancreatic neoplasm with associated mucin. So that was in about a month after this. Then they did a biopsy of this lesion, and they said intrahepatic cholangiocarcinoma. So like about 5-6 months before our last MR, they already made the diagnosis was mucinous neoplasm. This is intrahepatic cholangio. And
Victoria,
then
what are we adding to the discussion at this point?
I don't know. I was trying to figure out like why they sat on it for about 6 months. But but anyway, you're right. I'm sorry.
When I saw that case, it reminded me of this case. So I'm just sharing it as a compare contrast. So this is a patient who has this lesion in the left hepatic lobe, and it's subcapsular. It has kind of a T2. I presented this case before at these, and Yashant, so it might be familiar to you. But it's dark centrally, and then it's hyper intense on T2. And then this is the contrast, the multiphasic contrast. And so that's arterial, venous, and then 5-minute. And there's this more of like a central delayed enhancement here. The diffusion is here, and there's not really much of a diffusion in the area of the lesion. Any thoughts?
I feel like we're biased because you brought up hemangioma last time, but one thing that looks a little weird is that really T2 hypointensity in the middle, which you can see with sclerosed hemangiomas because they get really fibrotic and sometimes calcify. But I think this is still one you need to biopsy because it could be a cholangio. But
yeah, and so yeah, it was biopsied, and it was a sclerosing hemangioma. So initially, when I didn't see the pancreas, but when I saw that, it just made me think about this case, which has atypical and features that we would call suspicious with the peripheral enhancement and even with the T2 hyperintensity. But essentially, it is dark, very dark on T2. So.
Yeah, that's the times that I kind of bring it up is like if you see really dark T2 or a combination of like really dark T2 and then really bright, like there's still the little hemangioma parts left over. And then these like really fibrotic parts. That's when I bring it up more, but it can be super tricky and we have to biopsy. Okay. You guys see anything?
Yeah, in the mesentery, there's this kind of density. It's very ill-defined, kind of hazy density.
Thoughts?
I've seen like pseudomass, like inflammatory pseudomass that look like that. Other things I would say like desmoidish, kind of mesenchymal tumors.
Excellent, excellent. Yes. So this was resected and actually was a desmoid. And then, so that was gone, resected. And then a few years later, they came back and they had a very similar looking one up here. So, they did not have a like history of Gardner's or FAP or anything, but so a recurrent desmoid. And at that point, they'd already had like, they were like, okay, well, we already did surgery and then we got a recurrence, which is very common for desmoids. So they decided to use sorafenib. And this is the follow-up. And it completely disappeared.
Wow.
Yeah, within a year. It got smaller and smaller and then disappeared. So I just wanted to show you one little article. This is from the New England Journal, where they're talking about sorafenib for advanced and refractory desmoid tumors. And their conclusion was that it significantly prolonged progression-free survival and induced durable responses. So good new treatment, and we have an example of it.
So when do you use that over surgical resection?
I would have to ask the surgeons about that. I know that, they like some of them that if they're not progressing, so for example, abdominal wall desmoids, our surgeons are like watching some of those because they really don't want to resect them because it's such a high rate of recurrence. Occasionally they'll use like some like hormonal therapy, radiation therapy, and sorafenib. So I think at least this paper says when it's advanced or refractory. But they also said in general, there's no standard of care for how these are treated. So it's a multidisciplinary discussion. Because there are side effects to sorafenib, and actually this patient was having some of those. They can have rash, fatigue, hypertension, and diarrhea. 50% of people would have diarrhea, 55% with hypertension, 67% with fatigue, and 73% with rash. So it's not just completely benign.
Okay, I'll do my best, yeah. This is a patient who's being worked up for infertility. And this is great because like normally we do HSGs under fluoro to look for tubal patency. And this was an ultrasound version of it. Yeah, using contrast, I believe contrast. Oh, contrast enhanced ultrasound. Or hold on. It looks like contrast, but there's something very echogenic, and so they administer it, and then they look for the tubal, like the contrast or the agent, to then like distend the fallopian tubes bilaterally. Isn't that amazing?
That's so super cool. I've seen this with saline, like when we do a sonohysterogram.
Yeah.
I've seen them like trace it out with just fluid, but this echogenic stuff is even better, it seems like, because you can see it like, more distinctly.
Yeah, and it's incredible because I think it's really hard to find the fallopian tubes, right? And you can just imagine how amazing this technologist is to like be able to trace the entire tube under ultrasound.
Yes, very cool. I wonder if it is the same stuff they use for contrast enhanced, although it doesn't look like bubbles. And actually that's like I'm thinking like, are they injecting that into the endometrial cavity?
Yes, this was
Mm,
placed into the endometrial cavity.
yeah. Cool. But so you said it was a saline infused sonogram using what?
And so this was using diluted DEFINITY ultrasound contrast to evaluate the tubes.
Very cool.
So it was mixed. It was a diluted DEFINITY with sterile saline.
Nice. Okay, what do you guys think? Focus on the bowel. I'll show you on the lung windows. It looked a little foamy and fecalized. Some chat. Oh, okay, Yashant is back. Okay. So we were looking at this and we're just like, I don't know, is there some kind of weird malabsorption thing going on? Like normally we don't see the fecalization of the bowel like this extensively. Obviously fecalized bowel can be seen with bowel obstruction, but it can also be seen with just like generalized slow transit and stasis. I'll just kind of jump to the chase here, which is that when we followed it all, it looked like it was a lot of the small bowel, a lot of the ascending colon, and there was a transition in this area here. I think the coronal shows it better, where we saw this sort of like abrupt transition in this area here. It looked kind of collapsed, but it also looked kind of apple core. So brought up like, is this a colon cancer here causing a bowel obstruction? And that's exactly what it was. So it turned out to be a 2.8 centimeter stretch of circumferential colon cancer, causing this bowel obstruction. It actually was spreading beyond the serosa, which I don't think you can see well here. Sometimes you're able to see it well, but I don't think we can see that well. And then all of this small bowel stuff was just basically a, bad large bowel obstruction that was extending back into the small bowel.
So can you hear me?
Mhm.
So I had one of my favorite attendings years ago. He called it like he always taught us that if you see the stool pattern this way, it's almost like ground glass, very uniform, exactly the way you have it here. He
Mhm.
said, be very careful because there's most likely going to be an obstructing mass and look for it.
What
Like,
makes
when
the
this-
stool pattern that way from
it's
mass?
right. It's a completely like anecdotal. He was convinced that this and this is a conversation we had when I was a fellow, so a couple of years ago. But
Mhm.
since like I've always paid attention to it, and he's more like I think he's onto something. Although I don't know if I can prove it. His theory was that because you have this kind of incomplete obstruction for a while, and then the fluid is able to get through, but maybe like the stool kind of gets more dehydrated. I don't know. Like obviously he's just like his theory, but he did notice that when you have this this pattern of stool, look for an obstructing mass. Usually you see it like with like sigmoid and lower descending cancers.
I do
It's very
think that,
homogeneous, like
yeah, but
Yes,
what you're-
very, very
But not-
homogeneous.
and
I
not
think-
hard looking.
I like what you're saying, Victoria, about like maybe it's subacute, because if you have like an acute small bowel
Right.
obstruction, right? We don't see the whole
No.
bowel like this. It's like filled with fluid usually, but like maybe this thing
Mhm.
is like sort of slowly growing and basically like slowly
Correct.
causing an obstruction.
Correct.
Like
So that-
it's more like
right.
viscous stuff is getting like
Right.
congealed over time,
And maybe the peristalsis is what's kind of making it homogeneous, so it's just kind of
Right.
I have
rather
a
than
question.
acute constipation.
But if you start paying attention, I mean, this is not very common. You don't see it very common, but next time you see it, like look for it.
Yeah.
I have a question.
Mhm.
Don't we see a similar pattern of feces in cystic fibrosis?
Yes. Yeah. So actually that was one of the things we even brought up. We're like, this looks like DIOS, like distal intestinal obstruction syndrome. But those people have viscous small bowel contents because they're missing enzymes, right? This person did not have cystic fibrosis. So there's something, but like I think we're saying the same thing. Like something is causing it to absorb in a different way, like have some malabsorptive component to it.
So this patient has diarrhea and he has a history of CAR T therapy. So we see edema of the bowel. And I want to focus on one area. Let me pull up coronal. So what structure is this?
Ileocecal valve.
Yes. So there is edema of the ileocecal valve. And then this was biopsied and this was secondary to CMV.
So it's like a CMV enteritis. You said they were on CAR T therapy.
Yes.
Tell us more about that. I forgot what like that is for. I know it's for like some kind of tumors, right?
This patient
Like a
has multiple
blood
myeloma.
tumor. Yeah.
So CAR T therapy is basically, from what I remember, is you take out patient's T cell. No, you take out patient's B cells, you delete some of the receptors, I think CD20 or something. I may be wrong on that. And then you re-inject that, and those are then resistant to be killed by tumor, and then they can kill tumor. So basically, tumors have one of the markers which can suppress the T cells or the B cells to prevent their own killing. So CAR T cells do not have that. Maybe I can read that more and talk about it next.
Okay. And second question is CMV then a common side effect of getting CAR T therapy because you're like immunocompromised?
I think, yeah, any of these infections can happen because the patient is immunocompromised. This was just like, this is not specific for CMV. It was just like I was showing an ileocecal valve pathology. But yeah, any viruses or any bacteria which can happen in like, immunosuppressed state can do that.
Cool. I just Googled
Awesome.
CAR-T therapy and small bowel, and it also can just cause inflammation of the small bowel. So it seems like you would have had to have the biopsy here to say that this wasn't just a side effect of the CAR-T. Cool, thank you.